So long QT syndrome is, as I mentioned, that the QT interval on the EKG is prolonged, and the normal QT interval is about 0.4 to 0.44. So in this case, that is prolonged, and it is mainly the condition that affects the repolarization phase of the heart. The incidence of long QT syndrome is about 1 in 2,500 persons. And it may or may not show on the resting EKG. That's an important point to know. On the resting EKG, usually patients who have prolonged QT syndrome, the QT interval may be totally normal. So to diagnose this condition, sometimes we need to get the EKG during the exercise that can bring up the QT interval that is longer than the normal. So may or may not present on the resting EKG. In case if it's not present and if it is suspected, then we should do the EKG during the stress or exercise, or Holter monitor, which is the 24-hour EKG pattern. And long QT syndrome, as I mentioned in detail, that it's a repolarization abnormality. So this abnormality, if you see, will be in the repolarizing phase of the heart, or cardiac cycle, to be more accurate, is in the repolarization phase, which is the relaxation phase, not in the depolarization phase, which is the contraction phase of the heart. And usually it's not associated with serious consequences, so without consequences. And unsuspected, sometimes even nobody knows that the patient might have long QT syndrome. It can cause fatal arrhythmias, and these arrhythmias again are as a result of the poor impulse conduction that cause the abnormal rhythm of the heart, which are the dysrhythmias, but complete absence. A means absence. Arrhythmia, normal rhythm is all lost. So it can cause fatal arrhythmias, and these fatal arrhythmias can cause sudden cardiac arrest and sudden death. So very serious in condition might be in patients who are unaware, and they can have severe arrhythmias as a result of this prolonged QT syndrome. Now, the difference between normal EKG and the EKG with the long QT syndrome here, if you see, that's the normal QT interval from the beginning of the QRS complex to the end of the T wave. And the end of the T wave is again when the heart is completely relaxed, and then from the P wave another atrial depolarization start. This PQRST is known as the cardiac cycle. This is one cardiac cycle. If on a long strip of EKG, if we read these or we count these cardiac cycles, that is the heartbeat or the pulse rate in 1 minute. So if we run the EKG strip for 1 minute and count these cardiac cycles on that EKG strip, that is the pulse per minute or the heart rate per minute. So if we discuss one cardiac cycle, that's this P wave, QRS complex, and the T wave here, and this QT interval, which is from the beginning of the QRNS complex or before the Q wave to the end of the T wave, and then you can see the difference is really prolonged in long QT syndrome, and this is the disorder of the repolarization phase, so relaxation of the heart is affected. So big difference, it's more than 0.4 to 0.44. This is long QT syndrome. Now, some manifestations how the patient with long QT syndrome will present. Delayed repolarization of the myocardium, because we already mentioned it's the repolarization disorder, and if there is prolonged QT interval, there is delay of repolarization or relaxation of the myocardium. It will remain in the contracted phase, it will remain under stress, and that can generate different arrhythmias. Sudden cardiac death, very common because of, again, stress on the heart and rhythm is disturbed. Seizures can occur because of poor supply of the oxygen to the brain, because of poor functioning of the heart muscle. And then there is also syncope because of the, again, abnormal rhythm of the heart. So these are some very common manifestations of the long QT syndrome. Next, the genetic basis of the long QT syndrome. As I mentioned, it's the disorder of the protein and different genes that are associated with those proteins and those channels which are responsible for the generation of the impulse, transmission of the impulse, contraction of the myocardium, and generation of the heartbeat. When that is affected, different genes, this can cause the channelopathies. So different genes we have, it's an autosomal dominant disorder, long QT syndrome. There is only one condition, if I remember at the moment, which is due to autosomal recessive condition, and that's the sensory neural hearing loss. In that case, it's autosomal recessive type, but usually it's an autosomal dominant disorder. And it's divided into major genes, long QT syndrome, major genes, and major genes are, we have KCNQ1. This is usually responsible for type 1 long QT syndrome, and this is associated with the potassium channels. Another is KCNH2. This is associated with the type 2 long QT syndrome. And then the gene associated with the type 3 is SCN5A. So we have these associated with the sodium channels and potassium channels of the heart. Then another type is the minor genes. These minor long QT syndrome genes, we have AKAP9 and CACNA1C. These are the anchoring type and associated with the calcium channel. Next is the, again, CAV3 and KCNE1 and 2 and KCNJ5, SCN4B, SNTA1. These genes, they usually represent all those proteins and the ions responsible for the contraction of the myocardium and the generation of the impulse. And mutation in these major and the minor genes is responsible for the changes in type 1, 2, 3 long QT syndrome. Then we have long QT syndrome, which is acquired type of long QT syndrome, not due to mutation in the genes, but these acquired are usually due to some drugs taken that can cause the long QT syndrome. And commonly these drugs, we can remember them by A, B, C, D, E, and anti-arrhythmic drugs. These are the drugs that control the rhythm of the heart. Anti means against, arrhythmic, abnormal rhythm of the heart, anti-anginals. These are the drugs used for angina, which is the chest pain that can affect the rhythm of the heart. So these drugs, remember them by anti-arrhythmic and anti-anginal drug. Then B, we have some antibiotics also. Antibiotics are the drugs used for the different infections, and they sometimes also cause QT syndrome or prolonged QT. Then C, we have some antipsychotic, just to remember that it sounds like C, but actually it spells as PSY. So antipsychotic, but it gives the sound of C, so we put it here, antipsychotic. Antipsychotics are the drugs used for psychosis, which is a mental disorder, and it causes hallucinations and delusions, patients who have schizophrenia. So these drugs also can cause prolonged QT syndrome. Then D, we have some antidepressants and diuretics. Antidepressants used for depression, diuretics for blood pressure that increase, also known as the water pills. Diuretics very commonly known as water pill because they increase the urine output and they are used to control blood pressure. Then we have E, antiemetics. Anti-against, emetic, or emesis. These are the drugs used to control vomiting. They are known as antiemetics. So these are some acquired causes of long QT syndrome. We know it's usually congenital, mainly autosomal dominant, different genes, major and minor, associated with this long QT syndrome. But make sure you should remember that that's not the only cause. Some drugs are also associated with this QT syndrome prolongation or QT prolongation. And if there are symptoms that resemble that QT syndrome, and patient is on these drugs, make sure you should think about that this might be the reason behind these symptoms. Next, again, we have three main types of long QT syndrome, type 1, 2, and 3. And in type 1, the current that is associated with type 1 is mainly the potassium current. The functional effect of potassium is decreased, and then the frequency is 30 to 35% of type 1. Then type 2, again, current is the potassium, functional effect is decreased, frequency is less common as compared to type 1 and is 25 to 30%. And type 3 is in this you can see the current is different, the ion is different. First two was potassium, and the genes associated with those were also the genes which control the potassium channels. And this is here we can see the sodium is affected, current is sodium. Functional effect is increased, and frequency is not very common, is 5 to 10%. Now, diagnosis of long QT syndrome, that's the EKG, and we can see there is prolongation of QT interval if we measure them. Usually the measurement of these intervals can be on seconds, or we can just measure the squares that are covered. Here, how many squares, small squares and big squares. So all the leads mostly may not show the prolonged QT syndrome or prolongation of the QT interval. And again, we already discussed that maybe not visible on the resting EKG. We need the EKG during exercise. So some leads most prominently shows the prolonged EKG or QT interval is usually lead 2 and lead V5, V6 are usually the leads that show the interval that is long. So that's the EKG with the long QT intervals. Females usually QT is more than 460 milliseconds, and males it's more than 440 milliseconds. Treatment of the QT syndrome, long QT syndrome, it can present with the syncope or fainting, or it may be asymptomatic. Usually patients don't know that they have long QT syndrome. Treatment is beta blockers, very commonly used drug to control the abnormality in the rhythm of the heart. And these are also used to control the blood pressure. So beta blockers, we have nedolol and propranolol, both very commonly used beta blockers. Dose is 1 to 2.5 milligram per kg per day and 2 to 4 milligram per kilogram. So dose is dependent on the weight of the person per kg, and very commonly used beta blocker. They are the drugs that block the beta receptors in the blood vessels. And lifestyle modification is also always very effective, especially when the person is asymptomatic. They don't know what's going on, but person who have symptoms and they know, lifestyle management is very important to bring the function of the heart back to normal to some extent, to exercise regularly, and dietary management is also very, very effective.